It is no surprise that error and adverse outcomes are highly prevalent in resuscitation situations. This can be attributed to the interaction of multiple team members with different competencies, priorities, high patient acuity, time pressures, and communication breakdown. This assignment will review the coroner's report of Mrs. St. Mrs. St was a 55-year-old lady with multiple comorbidities including chronic renal failure, diabetes, coronary artery disease, and obesity. Mrs. St was attending hemodialysis for the first time when she developed abdominal pain 5 minutes into treatment. She was given paracetamol but shortly after complained of breathlessness and started vomiting. She became hypertensive and continued to deteriorate. A medical emergency team, MET, was activated 55 minutes post her initial complaint of abdominal pain. The MET team failed to provide sufficient oxygenation to Mrs. St, resulting in a severe, irreversible hypoxic brain injury. She was incorrectly intubated with the endotracheal tube placed down her esophagus. It was 20 minutes before this error was acknowledged. This was despite nursing staff recognising the CO2 detector had not changed colour and the patient's abdomen was distending. Furthermore, there was no oxygen saturations, nor end-tidal CO2 waveform. The patient was re-intubated correctly 20 minutes post the initial failed intubation. The lack of team leadership, poor communication, and impaired situational awareness were all contributing factors to Mrs. St's mortality and will be discussed in detail. The recognition and response to Mrs. St's deterioration will also be considered, as well as recommendations for future nursing practice. The coroner concluded that the misplaced endotracheal tube for approximately 20 minutes, as well as already being breathless for 45 minutes, significantly contributed to Mrs. St's hypoxic state. Furthermore, the noisy and chaotic environment may have been a contributing factor to the lack of assistance given to the anaesthetist. The coroner's first key finding was that communication was inadequate. There was failure of all staff to communicate their concerns to the group, and there was a lack of assertiveness on the presumed team leader's behalf. Secondly, there was no clearly defined roles and responsibilities of those attending the MET call. In particular, there was no clearly defined team leader nor coordinator. The coroner made 2 recommendations. Firstly, all staff involved in responding to MET calls must be familiar with MET call policies, procedures and equipment. Furthermore, they must complete annual competencies and documentation to this effect. Secondly, it is recommended that when staff arrive at a MET call, they should introduce themselves clearly, including their name, role, level of experience, and ascertain who is in charge of the MET. The first deficiency to be discussed will be the lack of leadership skills. Research on aviation leadership can be applied to medical practice. It is evident that in a crisis, 10% of people will take leadership, 10% of people will freeze, and 80% of people will follow leadership. Good leadership during resuscitation will result from good team coordination. Even an inexperienced team is able to provide good patient outcomes under the right leadership. The team leader does not need to be the most senior person, but instead the person with the appropriate attributes for the job. Good leadership in resuscitations requires someone who is able to take responsibility and verbalise it to the team, as well as someone who can make the hard decisions. It is essential the team leader is able to make the team feel safe and able to voice any of their concerns or thoughts. They should support, encourage and seek advice from other expert members of the team. It is reported that over half of junior medical physicians feel inadequately trained to take on leadership during a resuscitation. In the coroner's case described, Dr. T reports not knowing other doctors in the room and assuming that Dr. D was in charge. It is evident that there was no communication about who the team leader was, nor any official role allocations. A lack of assertiveness by the team leader was further described. Trauma Victoria 2019 recommend early allocation of team leader, verbally stated to ensure the rest of the team know who will be in charge. The team leader needs to be clearly identifiable and should stand at the foot of the bed directing the resuscitation, making the hard decisions and prioritising care. The team leader should also allocate roles and responsibilities to the rest of the MET team, ensuring they are within their scope of practice. Alright, I'm going to be team leader. Caitlin, you happy to do airway?
Yep, thank you.
You happy to do drugs then,
Yep.
Lauren? And Laura, can you do scribe, please?
Yep.
It is recommended that the team leader will seek advice and feedback from others. Leadership and team training are recommended to improve team performance during resuscitation. Specifically, simulation training assists in leadership and teamwork development and should be implemented in both undergraduate programs and continuing professional development programs. The allocation of the most senior nurse to team leader could also be considered. It is evident that having a nurse team leader improves some aspects of communication and leadership. Communication is a second deficiency to be discussed. Dr. T reported asking for assistance with the intubation several times and not receiving a response. This potentially attributed to the unsuccessful endotracheal intubation. This is evidence of poor communication and an absence of closed-loop communication between the team. A common barrier to preventing good communication is the authority gradient that exists in the medical practice. It is evident that those at the bottom of the hierarchy may be hesitant to speak up, challenging others within the team. This is particularly evident in some cases of nurse-to-doctor communication. The dangerous hint and hope communication style is often adopted by nurses when communicating to doctors. This was evident in the well-documented coroner's case of Elaine Bromley. The nursing staff in this case hinted at medical staff for the need for a tracheostomy due to multiple failed intubation attempts. Nursing staff did this by placing the equipment in the room and stating it was available. They, however, failed in assertiveness and did not impose closed-loop communication with the medical team. This was a contributing factor to the patient's mortality. The hint and hope communication is also common for junior medical staff when trying to speak up and then ignored. They fail in assertiveness. Closed-loop communication is broadly accepted as being gold standard for communication in an emergency situation. Closed-loop communication leads to improved patient safety, decreased adverse events, and error prevention. 37% of errors within the ICU are preventable and can be attributed to communication breakdown. Furthermore, miscommunication can be attributed to 67% of preventable deaths in trauma patients. Higher hospital mortality can be attributed to communication errors than incompetent clinical skills. Side conversations, equipment noise, and family noise are all barriers to good communication. Closed-loop communication results in a significant decrease in time taken to complete tasks. These tasks include, but are not limited to, medication orders, intravenous lines, and collecting pathology. Thus, it is evident that closed-loop communication leads to better patient outcomes. Closed-loop communication should be an integral part of team leader training. Closed-loop communication is a two-way process where the sender must deliver concise information. The receiver acknowledges the information and repeats it back to the sender, ensuring correct understanding. The sender then confirms the intended message was received. The loop is closed by the receiver communicating the task has been completed. Closed-loop communication reduces errors and adverse events by ensuring the question was heard and interpreted correctly, and allowing the opportunity for the instructions to be questioned for clarification. It also keeps the other team members in the loop of what has been asked. Names should be used to ensure the task requested is completed. This gives someone specific ownership over that task. Communication should be assertive and non-threatening. This ensures the message is delivered with the appropriate sense of urgency while also being respectful.
Okay, Tana, can you give 1 milligram of adrenaline, please?
Yes, I can. 1 milligram of adrenaline given.
Thanks, Tana.
The third deficiency to be discussed is situational awareness. A broadly accepted definition of situational awareness is the perception and comprehension of relevant cues assisting the prediction of future events. Situational awareness is being able to see the big picture in the absence of tunnel vision. Tunnel vision can be common in resuscitation environment and results in the fixation of one thing at the detriment of everything else. Situational awareness can be impaired by mental and task load, time pressures, distractions, and fatigue. Where nurses fail in situational awareness, patient safety is jeopardised and poor decision making is evident. It is proposed nurses with good situational awareness should notice subtle changes in patients' assessment, inclusive of vital signs, and think ahead to possible adverse outcomes, thus predicting and reducing adverse outcomes. For example, with good situational awareness, in the case of Mrs. ST, it is probable that nursing staff could predict the endotracheal tube was not in the correct position based on the clinical signs, lack of colour change and CO2 detector, and the patient's distending abdomen. It is important to acknowledge the importance of not only individual situational awareness, but also group situational awareness. This can be achieved by adopting the shared mental model. The shared mental model, everyone is familiar with everyone else's roles and are able to anticipate the needs of the whole team. Individuals come together reporting their findings back to the group so that knowledge is shared, subsequently allowing the team leader to build on information already known. In order to gain team situational awareness, the team leader should outline priorities to ensure everyone is on the same page. This prevents two people from trying to complete two counterintuitive tasks simultaneously. For example, an anaesthetist trying to intubate while someone else is trying to relocate a dislocated limb. Feedback from the team should be invited to ensure shared understanding. Simulation education is best practice for improving situational awareness. It is recommended that this learning is supported with constructive debriefing. The fourth deficiency to be discussed is the recognition and escalation of patient deterioration. Recognising and responding to the deteriorating patient is a quality standard set by the Australian Commission on Safety and Quality in Healthcare. It is evident that in-hospital adverse events, such as unexpected death or cardiac arrest, are often predictable by deterioration in vital signs. Therefore, early recognition and response to those changing observation is paramount to patient safety. It is suggested that rapid response systems, such as METCALs, are associated with reduced rates of cardiac arrest and mortality. However, despite this, nurses understanding the METCAL system and the importance of early recognition and reporting of patient deterioration, the system does still fail. Sandroni and Carvalho, 2011, report on a study where only 30% of MET calls were made in a timely manner for patients meeting MET criteria. These patients later required an unplanned ICU admission. These delays are directly related to an increase in hospital mortality. Barriers to making the MET call includes high workloads, negative behaviours of the MET team members, and hierarchy issues. It is also reported that some nurses still lack awareness of the significance of monitoring, documenting, and responding to the patient's changing conditions. Despite the implementation of MET teams, in this coroner's case, Mrs. ST's outcome was still poor. Mrs. ST's first complained of abdominal pain approximately 15 hours and was given paracetamol. Soon after, she complained of breathlessness and began vomiting. Her blood pressure increased rapidly and she deteriorated. MET call was activated at 16:10, 55 minutes post her initial complaints. With the information provided in this coroner's report, it is not clear if the patient's observations were breaching MET criteria prior to this time, or if there was any indication that MET should have been called earlier due to nurse concern. It could be hypothesised that if the MET call had been activated sooner, when Mrs. ST first complained of breathlessness, the outcome may have been different. However, this is outside the scope of the provided coroner's report. Ongoing training of hospital staff in MET systems in order to remove barriers. Regular audits and feedback from MET calls also improve compliance. Furthermore, administrative support as well as senior medical governance is reported as essential for the implementation and compliance of MET systems. Proactive rounding and increased frequency in patient observations for those at increased risk of deterioration is essential. Furthermore, regular simulation training is recommended to improve escalation of patient care. Building a supportive and communicative culture is also proposed to enhance escalation of patient deterioration. Overcoming nurse lack of confidence to make MET calls should include promoting MET call systems based on subjective findings, not just patient observations. This includes METs based on nurse concern or worry. This may have been helpful for Mrs. ST. She may not have been objectively breaching MET criteria, however it was apparent that her condition was deteriorating. It is possible that the nurse caring for Mrs. ST could have made a MET call prior to her observations breaching MET based on nurse concern. Upon extensive review of the literature, it is evident that deficiencies in leadership, communication, situational awareness, and early recognition and escalation of patient deterioration all result in poor patient outcomes. Performing well in these non-technical skills is even harder in the highly stressful, noisy, and chaotic resuscitation environment. It is evident that training in these non-technical skills is just as important for health professionals as training in technical skills. The coroner report of Mrs. ST is just one of many concluding that the lack of leadership, communication, and situational awareness leads to devastating patient outcomes.